Thank you very much for inviting me to give this talk to you at your National Congress. When you see a distal radius fracture like this, there's a lot of things that you think about in terms of how you can fix this. And for a lot of people, a dorsal spanning plate is a good option for this type of fracture. Now, I will say that since the introduction of the dorsal bridge plate or spanning plate, it's been used with quite a bit of frequency. But now I think people are using the dorsal plate in fractures that don't necessarily need it, or fractures that are inappropriate for a dorsal spanning plate. And so my talk today is to share with you what I think is the role and the rationale of the bridge plate, but more importantly, when you shouldn't use it and what the limitations of the bridge plate are. So what's the goal of fixing a distal radius fracture? Well, you want to restore the articular surface and align the distal radius articular surface to the shaft. And it should be stable enough so they can get back to their rehab and their normal daily living activities, but hopefully in the end you minimize their dysfunction and get them back to as good of status as they were before their injury. So what's the rationale for using the bridge plate? I think that is the question, is to tell yourself, are you going to use it as a spanning plate to neutralize the fracture with whatever other type of fixation you have, or to use a ligament ataxis to distract the fracture? So here's some two examples. Here is a dorsal spanning plate or a neutralization plate. A patient who had this very comminuted intra-articular fracture with metaphyseal comminution. You can see here the amount of displacement and the high level of comminution. And here, I first put the dorsal spanning plate, where here you may even say it's a distraction plate just to get length out. And then I put the volar locking plate on to reconstruct the articular surface. But because this patient had poor bone, a lot of bone loss in the metaphysis, I left this plate on as a neutralization device, or just a purely dorsal spanning plate. And here she is immediate post-op, and here she is 2 weeks after that bridge plate comes off, or the spanning plate. And so it was used to neutralize the forces while this heals with a volar locking plate. The other option then is to use this as a distraction bridge plate. Like in this patient here who had this really comminuted distal radius fracture. And here, with ligament ataxis, I can try to get these pieces out to a reasonable position and to hold it there with distraction. To do that, you have to understand that all these small fracture fragments have ligaments attached to them. And these fracture fragments are fairly consistent because these fracture lines typically occur in areas between ligament attachments to bone. And so this volar rim piece, or this radial column piece, this dorsal wall piece, have ligaments attached to them that you can use to get distraction. And here are the volar ligaments, the short and long radial lunate and the radioscaphe capitate, which you can use again to use ligament ataxis to get these better reduced. On the dorsal side, really, it's just the wrist capsule and the dorsal radiocarpal or dorsal radiotriquetral ligament is the only thing you can use to pull on the fragment. Now, the problem is that the attachment of the DRC, it may not actually grab the dorsal honor corner fragment if it is displaced and impacted. Like in this patient who I use ligament ataxis to try to get reduction, but that dorsal honor corner piece, no matter how hard I pull, the ligament is not attached to here, so it won't pull it out. So in these fractures, you can't just rely on closed traction to get ligament ataxis. But in this patient here, recognizing that all these pieces have a ligament attached to it, using this as a distraction bridge plate, I could get it into pretty good alignment. And here he is at 4 weeks. And here he is right before the bridge plate comes off. And that everything looks pretty good. And that was purely using this distraction bridge plate to hold everything in the right spot. And here he is at 3 months after the bridge plate came off, so really 6 months from his initial injury, and that outcome is pretty good. So what are the indications for the bridge plate? These are the indications that have been described in the literature. There's a lot of good reasons to use it. There's some pros and cons though. The pro is that in a lot of times, if you don't have to open up dorsally, it preserves fracture biology. Compared to an X-fix, you don't have external hardware. And the bridge plate or the dorsal plate does a really good job of aligning the articular surface to the radial shaft and making them collinear, and aligns it really nicely, especially when you have a volar translation or volar shear or dorsal translation from a dorsal shear. The disadvantage is you have to have another surgery to take it out. You can have wrist stiffness or even hand stiffness, finger stiffness. And if it's a open injury like this, putting in that plate may be a reason for them to have an infection, persistent infection. This is how I put in the bridge plate. Like in this patient here that has a very distal, comminuted distal radius fracture, I first lay the bridge plate over the hand, and I get a mini C-arm shot, and I just outline the plate over the second metacarpal. Make a small incision. I don't dissect under the periosteum. I just find the second metacarpal, and if you find this and you trace that proximally, that's where you'll get to the the ECRL and the ECRB, and you want to find that area because then you can get a freer up into this area, and then you have an area that you can slide your dorsal spanning plate in a retrograde fashion, which is what I typically like to do. Instead of having an inserter, which are available, I like to use the locking drill tower as a handle, and then I can slide that up, and as soon as I have that in the right position, I can put that screw in. Just be mindful that the dorsal cortex of the metacarpal, it's not entirely flat, so you can mal-rotate this or put this on the radial side or the ulnar side of that second metacarpal. So try to get a perfect PA of the second metacarpal when you see the two collateral recesses, and that plate should be right on top of there. I use a non-locking screw to suck that down, and then I put 2 additional locking screws to hold that down. Next, I localize the proximal incision. I cut down, and you should see your outcropper, your APL, EPB muscle bellies here. And then right proximal to that, you should not see your plate yet. What you should see is an incision over the fascia, and then you'll see your ECRL, ECRB, and the plate there. I first put a screw here just to hold my tension, or even you can clamp it, and I make sure I haven't over distracted them. And to gauge that, I see if I can passively flex the hand, and if I can, then I know that I haven't introduced any extrinsic extensor tendon tightness, and I say that that's enough distraction. And then if I need to, I'll do a dorsal approach, disimpact, bone graft, and then here I put a little rafting pin to hold that together. And I think that's a pretty good outcome for using this as a distraction bridge plate. So here are just some cases of using a dorsal spanning plate or a dorsal or distraction bridge plate. So here this patient had this distal fracture, open injury. And in this patient here, I didn't want to put too much permanent hardware. And so I put this bridge plate on. So if you look at this, just critique this. Do you think it's acceptable, or would you modify things? I think you'll recognize is that this fragment is radialized. And so with this one screw in here, I can loosen it, pull this over to get that radialization corrected. Now I can get the tension on my distal band of the IOM better, more anatomic, so now they have a little more DRUJ stability. And here she is with this dorsal spanning plate. Now look here, critically, does that look okay? And I would say that this volar rim piece, it's a little too extended. So I use this very small fragment-specific device to get that better reduced, restore my teardrop angle. And now here she is after the plate has come off. How about this patient here who had this very distal fracture? And here you would say that a volar plate probably won't work. Even a fragment-specific name may not be appropriate because it's very, very distal and very small. And this patient had a same-side clavicle fracture. And so I use this dorsal spanning plate because, in addition to a volar locking plate, because I didn't feel like the volar plate would capture this effectively, and I didn't want the carpus to translate volarly, so I use this dorsal spanning plate. So now, even if this fracture fragment is not stabilized by this screw, this carpus is not going to go anywhere because you have this neutralization dorsal spanning plate. So I will use this often if I use the volar locking plate and I feel like this fixation may not be strong enough and it may not be stable, then I put this dorsal spanning plate, really to prevent any instability of this volar rim fragment. So there are some limitations though. If the patient has a malunion of the distal radius, the bridge plate will not accommodate that. And so if you do that, then the carpus may not be aligned with the distal radius. I think probably the biggest thing is that especially when the bridge plate is placed on the third metacarpal, which is why I don't put it on the third metacarpal, you can get a lot of extensor tendon adhesions and even ruptures. And probably the biggest limitation is people feel like you can put a bridge plate without doing an open reduction and get everything perfect, which a lot of times you can't because ligament ataxis alone may not reduce things properly. Like in this patient here, has this volar rim fracture, shear fracture. And here I put this distraction bridge plate only, didn't open it up. And now critically, you can see after the bridge plate comes off, I completely malreduced this. This was early on when I was using the bridge plate with a lot of enthusiasm. And here, I did not do the right thing for the patient here because I try to use the bridge plate, the distraction bridge plate, inappropriately. So I found that in these volar shear fragments, if you try to do ligament ataxis, you can't disimpact this. You may correct this teardrop angle, but it's hard to get that to come out. And so those, you have to do a separate volar approach to fix that. What you can do is use it for a dorsal bending mechanism. The bridge plate will actually help quite a bit to get this volar rim fragment restored. So in that situation, it's okay, or it's a little easier to do than a volar shear type of fracture. Well, how about this patient here? Had this fracture here. Here's a CT scan, very distal, comminuted. I put this dorsal spanning plate or distraction bridge plate to try to pull it out to correct that dorsal bending mechanism. And that dorsal ulnar corner piece was still unstable, so I just I did a direct open reduction and put a pin in there to stabilize it. And here you can see that with that dorsal spanning plate, because she had a previous fracture in the distal radius, it made my dorsal spanning plate pull the carpus fully dorsally. So you have to be aware of that. And now you can see with that plate off, it kind of normalized, but you have to be careful because the dorsal spanning plate, because it's so strong of a plate, it'll align the metacarpal to the radius. And if there's any malalignment or malunion, it will cause the carpus to sit malreduced in the radiocarpal joint. So last thing I'll say is no matter how simple or how hard a distal radius fracture looks, I would always have the bridge plate or the dorsal spanning plate available. Like in here, I thought I could use a volar plate. I had an open reduction, put a volar plate on. I'm distal to the fracture fragment. So then I tried to use a fragment-specific device. And after trying to get it into this small piece, I completely fragmented it. So then here, only thing I had left was a bridge plate. So I went through the algorithm of a volar plate, fragment-specific device, now a bridge plate. And that was the only thing I could do. It's not perfect, but I had no other option. It was either this or an X fix, and I'd say still the outcome was decent for a really, really bad fracture when there was no other option. So my summary points are just if you need to remind yourself why you're using a bridge plate, just ask yourself, are you using it as a neutralization dorsal spanning plate or a distraction bridge plate? And no matter what you use, bridge plate, folder plate, distraction or fragment specific, fix these in a stepwise fashion, one fragment at a time. I would always have this available because it's a good bailout if nothing else works. And just because you're doing a bridge plate or a dorsal spanning plate doesn't mean you can accept a malunion, articular malreduction. You can make it perfect with the bridge plate as long as you know how to use it properly. Thank you very much for inviting me. It's an honor. Please be safe.